Hi, this is Thaddeus Pope, and this is my presentation, Revolutionizing Informed Consent Law and Practice, Empowering Patients with Certified Decision Aids. So a few weeks ago, Portugal enacted a new law, a patient rights law. And a lot of this law focuses on informed consent, the patient's right to informed consent. And that's great. That's a great accomplishment. Portugal should celebrate the enactment of this new law. But declaring legal rights is not enough. We know that there's been a long-standing gap, a chasm between the theory of informed consent and notions of patient self-determination and autonomy on the one hand, and medical practice on the other hand. Fewer than 10% of patients understand the health care that they're getting. So a way to bridge this gap is with patient decision aids, and I'll refer to them as PDAs. What I want to talk about is how the law is pushing, how the law can push wider, greater uptake and use of patient decision aids. Right, even looking around this conference, we see a lot of developers of decision aids and other educational tools, but they complain that nobody's buying them, nobody's using them. So what are PDAs? Right, they're evidence-based educational tools. There's two basic types. They can be used before the patient-physician encounter. So, for example, might be a video, might be an interactive website, an app, or just well-designed visual literature. And then there's decision aids that can be used during the patient-physician encounter. So, for example, an option grid. Either way, what these decision aids do is they present the patient her options clearly and graphically. Do they work? Yes. There's robust evidence that shows that decision aids are highly effective. Right? There's now been more than 130 randomized controlled trials. They've involved more than 30,000 patients with 50 different conditions. Those studies have been reviewed systematically, meta-reviews by the Cochrane collaboration, and so we know there's good evidence that patients that use decision aids have improved knowledge, that they have more accurate expectations from their healthcare, that they have lower decisional conflict, and that they make more value congruent choice. In short, there's great evidence that they have a lot of great outcome benefits. So what's the problem? Well, the problem is that too few clinicians are actually using decision aids. There was a study published earlier this year called National Strategies for Implementing Shared Decision Making. And it looked at implementation in 9 countries. It notes that more work has been done on shared decision making in the United States than in any other country. Still, it hasn't been incorporated into mainstream care. And what this report talks about uses the term external influences, things like policy and law that can help promote wider uptake of shared decision-making and decision aids. So that's what I see as the challenge, which is to move decision aids from research to practice, from the lab to the clinic. So there's 3 legal tools that we can use to make that move. There are liability tools. So, for example, in the state of Washington has enacted a law, and what that law does is it provides safe harbor legal immunity to clinicians that use decision aids. It sort of operates like a legal shield. If you get extra liability protection for using decision aids. So this is sort of like a positive incentive, a carrot. We could also use a stick, sort of a negative incentive, and therefore impose wider liability exposure for not using a decision aid, but we haven't done that yet. We could have, in addition to liability tools, we could have mandate tools. So, for example, the state of California has a lot of laws that the medical board in California refers to as mandated standardized written information. For example, if a woman is diagnosed with breast cancer, she must be given this state government approved booklet, which gives her a lot of information. But we could be using decision aids instead of mandated standardized written information, although we're not doing that yet. And then third, so we have liability tools, mandate tools, payment. I want to focus on payment tools. So here, our biggest payer in the United States is Medicare. And Medicare is not only the biggest payer, but when Medicare makes a policy move, other private and public payers usually follow. Well, what Medicare has done is made the use of decision aids a condition for payment. Basically, what this means is if you don't use the decision aid, then you don't get paid. Well, the logic of this is pretty straightforward. Medicare only pays for medically necessary health care. And medical necessity is not a purely clinical determination. Because if the care that's provided is unwanted by the patient that is receiving it, then it's not medically necessary. So over the past few years, Medicare has increasingly required the use of decision aids as a condition of payment. So let me give you three examples. One is screening for lung cancer with low-dose computed tomography. So this is for long-time heavy smokers, and they get a chest CT scan. But before they get the CT scan, they need to have a shared decision-making visit. And that visit has to include one or more decision aids. And Medicare notes that there are a number of decision aids available for that purpose. So, for example, this is a printed decision aid. Is lung cancer screening right for me? It uses different graphical information to present the risks with screening, without screening, and it helps guide the patient to clarify her values about what she cares about. Another example of a payment tool, implantable cardioverter defibrillators. So these are little devices that deliver a shock to restore a normal heartbeat. And again, before implantation, this is a covered benefit. Medicare will pay for the ICD, but before implantation, again, the patient needs to get a formal shared decision-making encounter, and that has to include the use of an evidence-based decision tool. And then a third example, percutaneous left atrial appendage closure therapy. The left atrial appendage is a source of blood clots that can cause stroke. The traditional way to deal with that is with an anticoagulant like Coumadin, but now there's a medical device alternative to that called the Watchmaker. It looks like this. And it's basically inserted to block off the left atrial appendage. But again, before implantation, the patient has to have a formal shared decision-making interaction. and that has to be with an evidence-based decision tool. So to recap, right, there's been this growing use of legal tools, but still it's pretty rare, right? I've only been able to give you three payment tool examples and one liability tool example. That's all there are, basically. And that's because there's an obstacle to wider use of legal tools. And that's that decision aids are of widely varying quality. And we can't really attach legal consequences to their use or non-use until we can assure their quality. And the way to do that is with certification, right? Somebody to make sure that the decision aid is accurate, that it's up to date, that it's free of conflicts and bias and conflicts of interest, and that it presents the information in an understandable way. The state of Washington has a certification process and a certification entity, but we don't have any such certification process or entity at the national level, and we need one. So in conclusion, right, informed consent is too important to leave in the hands of physicians. If we could certify decision aids, we could have more legal tools. If we could have more legal tools, that would prompt more use of decision aids. And if we would have more use of decision aids, we would have better quality healthcare. Thank you.